Our first talk is a double act. We have Kate Lloyd, who works with the Agency for Clinical Innovation, and she brings a broad experience, having worked both in the public and private sector across areas as diverse as equity research, international education and health economics. Kate's got a Bachelor of Science in Biology and Chemistry, as well as holding a Master of Public Health in Health Economics. And Yeung is currently working as the program lead for the In Safe Hands program. And let's welcome Kate and Wilson as they come and do Managing the Inpatient to Prevent Readmissions.
Okay, so I'm going to talk, as Annette said, about strategies to reduce readmissions by managing the inpatient well. And I'm going to go through a project that we're running at the Acute Care Task Force called Improving the Inpatient Journey. I just thought it would be a good idea. This slide won't be new to most of you. You know what the structure looks like for New South Wales, but I think it's a good idea to revisit what structures we have in place to support the work that we do, supported by 6 pillars at the side, and also to focus a little bit on the roles of the Clinical Excellence Commission and the Agency for Clinical Innovation. When I talk to people, sometimes there's a confusion about what the different organisations do, and my answer is usually ACI's focus really is primarily around models of care, and the CEC's focus is primarily around quality and safety, but there's this huge opportunity for us to collaborate together, and certainly Wilson and I work really closely on the work that we do. So my focus is really around the during hospital admission strategies. So there'll be some other talks today about before hospital and after hospital, and linking the two up as well. So this is a really busy slide. It's got lots of information on it, but it's designed to show what the Acute Care Task Force is working on. So focusing in on the inpatient journey around clinical management plans, structured ward rounds, patient flow systems, so using estimated date of discharge and waiting for what, criteria-led discharge and transfer of care. And we tried to identify who in the system was leading on pieces of work so that we weren't going out and duplicating and doing a whole lot of work that was already being done. So ACI picked up clinical management plans and criteria-led discharge because at that point in time no one was leading on that work. And of course linking really closely to whole of hospital, hospital in the home, and medical assessment units also sit under the remit of the Acute Care Task Force. So they're a really important strategy within the hospital to reduce readmissions for that chronic complex patient. I'm not going to focus too much on the medical assessment units, but we do really see them as one of the important strategies. I've stolen this slide from Wilson. He'll show you it again. Because I think it's a great slide, and it's certainly what we've learned. We've been out collecting patient and staff experience data as part of our testing, and what we found was that 39% of patients knew when they were going home. And I think part of this is driven by the fact that 51% of staff reported updating an estimated date of discharge as the patient moves throughout the hospital journey. And so I think those two things drive each other, and patients are really just left in the dark a lot of the time. We found a disjoint as well between what patients were hearing. So 58% reported that they get an update every day, and 67% of staff said that they give the update. So a bit of a gap between what patients and staff are telling us happens. And when we asked patients, we thought the important question is, do you get asked the same question all of the time? But patients didn't seem too worried by that question. What they seemed more worried by was the fact that they get told different pieces of information. It's the nurse tells them one thing and the doctor tells them another thing, and they don't quite know who, and then there's a lot of confusion, and it's a real, I think it becomes quite a safety issue. So starting with clinical management plans, we got a working group together, and the goal really was to develop up some principles and then some tools to support this work, and then go out into the system and do some really rapid testing. So single comprehensive assessment, and that's about the risk assessment as well, that really early risk assessment for discharge planning purposes. And we've been using what's called the B and W methodology, not very snappy in terms of an acronym, but it's really about before, now, and why, and understanding the patient's functional status before they're in hospital and now, and trying to determine the why, and identify that risk early on. And seeing partners as patients as partners, and really understanding that they have most of the information, or their carers have most of the information about themselves, and they really are experts in their own care. And certainly when we asked patients, there wasn't that great view that they were involved in the discharge decision-making process. They were seen as separate to that process, and we'd like to see that improved. Multidisciplinary team documentation, and single medical record, everyone's documentation in the same place, so everyone knows what's going on. Transparency of management plan. Not new things, but things that when we go to examine what happens don't necessarily happen in practice. And structured approach using ISBAR, and also a structured approach, so using a structured approach to documentation as well. So I'll go through some of the tools that we've developed. And confirm, don't repeat. I mean, we see, this won't come as a surprise either, reams and reams and reams of repeated information throughout the medical record. So it's about acknowledging your colleague's work and then reviewing and revising that particular piece of information, but not repeating it. I think this one is often thrown up as linking to primary healthcare plans, as we don't have the system in place to link this work in. And it's as easy as a phone call, or it's easy as asking the patient, do you have a plan from your GP or your Aboriginal medical service or your aged care facility? Does one exist? Do you have it with you? All that kind of stuff. So trying to link into that work. So we developed 3 tools that we're out and testing at the moment. This first one we're currently using as an overprint on a progress note. So it becomes a part of the medical record and part of the progress note. So it's the same kind of concept: acknowledge, review, refine. It has a safety checklist down the side, so you're adding a structured way to identify what risks are occurring with the patient. A place for updating the estimated date of discharge in the top right corner as well, and who was present in terms of the documentation. So the idea that you would do this perhaps on a ward round is the way that's currently being tested. Problem management sheet sits at the front of the medical record, not necessary for all patients, but for those complex patients who often have really complicated care needs, and you are managing multiple conditions. So this is just a real snapshot of what's happening with the patient. Teams have reported really liking this, really finding this valuable, so they don't have to flick through the medical record just to get a snapshot. And then the final tool for clinical management plans is around weekend handover. This has been good for teams that have high locum use, or a medical team on the weekend and the weekday that's totally different, and that don't traditionally have that sharing of information. And it's got the weekend contact, and also a section down the bottom, so it's the bottom of the sheet, to say that the person has read and acknowledged. So in terms of handover, that real acknowledgement. And then on to Wilson for his slides.
So I guess George Bernard Shaw was correct in saying the single biggest problem in communication is the illusion that it has taken place. I think that's due to, in health especially, because we're so busy, we think that we're communicating what we're doing to the bedside nurse, or to the medical staff, or to the allied health staff, but it doesn't usually happen. But when we look at the root cause analysis reports that we at the CC we look at, the universal root causes are really about, in regards to the causes of adverse events, are really due down to communication, teamwork, and coordination of care. So what the InSafe Hands program is about is really through structured team rounds. So the CEC has actually been working with Jason Stein from Emory University Hospital at Atlanta, in actually implementing a structured round process. So in Emory they call it SIBR, Structured Interdisciplinary Bedside Rounds, but I refer it to structured team rounds here. Basically, we're aiming to, through the structured team rounds tool, we aim to enhance teamwork and communication, improve patient safety, engage and involve the patient and family carer at all times, and to bring everyone together to the point of care to make key decisions. So as part of the structured team round, we've developed a round communication structure. So basically there's 5 phases in the structure. 1 being the introduction, 2, review of issues, test results. So you'll see that it's a scripted conversation. I should mention that it's a scripted conversation where each member of the team has a say and has time to actually verbalise any concerns and the like. So the usually junior medical staff or the registrar will do the introduction and the review of issues and test results. The nurse will update current status and also go for a specific patient safety checklist, and also allied health inputs will be part of that phase as well. And also at the end is to summarise the plan. So the medical staff will summarise the plan for the whole team, so everyone is on the same page. Everyone has the same shared mental model in what's going on with the patient. So I guess what we've built into this round communication structure is also to actively discuss the waiting for what question in the second phase. So what the patient is waiting for, that's permitting them from being discharged or to be transferred to the next point in care. And also the EDD and needs for transfer of care will be discussed as well at the end of the round. And those conversations can be, what does the patient need before they go back home, and anything else that they might want to discuss. But at the end of the day, the patient and family are actively involved in this process. So they have points where they have an opportunity to ask questions, get questions answered, and have things clarified as well. So this is just a summary board that's from Orange Health Service. They've actually got these on the ward that they have implemented the structured team rounds, and it basically shows all the information, key information for the patient. So we know what the plan is, we know what the EDD is, the patient goal for the day is there, and patients and family can have an opportunity to ask questions, write down questions as well. And when those things are addressed, they're actually ticked off by the bedside nurse. So what's different, I guess, to current rounding processes already? Because I know that a lot of facilities and units are doing rounds. Some might be doing really good things, so we don't want to say that this is the way to go. But so what's different with what we're doing is that the patient is an active participant during the round. It happens regularly at the same time when it is scheduled. So for example, at a aged care rehab unit in Sydney, they've actually implemented this. They have a 20-day length of stay, so they don't do it every day, they do it on Monday and Thursday, because it gives them an opportunity of a whole team, allied health, nursing staff, and the medical staff to come together and share all the information together and really knowing what the plan is for the patient. While other teams, such as a neurosurgery unit in Sydney, they actually do it 7 days a week. So it's a customizable model, so you don't have to abide by any rules, but I guess the thing that you need to abide by is really this communication structure, and to have everyone, the relevant disciplines there on the round, and key decision makers on the round as well. And also, this is it's a brief discussion for each patient, so it only usually between 3 to 5 minutes for each patient. And the detailed discussion will happen after the round for each discipline. For example, if a social worker needs to go back to see the patient, they will do that on the course of the day. So it's really, again, what I want to emphasise is an opportunity for the whole team to come together to the point of care and involving the patient and family as part of that care. Here's also what's different. Again, what I said before, family and carers are encouraged to be part of the round. Patient's goal of the day and care plan is understood by everyone. the patient family carer has an opportunity to ask questions. Here are some benefits that we've seen with the rounding processes that we have implemented across a number of sites in New South Wales. We're currently working with 23 sites. Some facilities are actually planning to roll it out across the whole facility. So there are places that are in various stages of implementation and planning as well. The other thing is what Greg talked about in regards to the mentored implementation approach really struck a chord in what we're doing with In Safe Hands, because we are building up a group of units that are actually quite well versed in implementing this and are doing this. And what our plans next year is to use those sites and buddy them up with any other sites that are wanting to do this as well. So for example, if an aged care unit has done it, we'll buddy it up with an aged care unit that's thinking about doing it as well. So we're trying to do that mentored implementation approach as well with this program. Here are some other benefits. What we've seen so far is that they've got really good feedback from patients and carers, enthusiastic adoption by medical, nursing and allied health teams, time efficient, staff satisfaction, and basically enhances teamwork and communication. Some other benefits for the patient: involvement, empowerment, confidence, certainty in knowing what's going on. Early evaluations that we're doing, we are doing a formal evaluation at the moment on a number on one site, and also next year as well. Basically, we've seen improvements in patient safety. So the safety checklist that I showed you in phase 4 is basically the unit comes together and decides on what they want to concentrate on in addressing. So for example, I'm currently working with an emergency department who's thinking about taking this model on, and they'll be the first ED that would be doing this. They've actually included sepsis and also VTE as part of their patient safety checklist, and also pain as well. And I think those three things already have protocols and guidelines that are associated with it. So what we're trying to do in the CEC is also to link up a lot of the CEC programs like falls, pressure injuries, etc., that we have done, and linking it into the safety checklist, so that, again, what Greg was alluding to is like protocol-driven care as well. So we have standardization in regards to addressing those specific potential adverse events. So care coordination has improved, clinical outcomes, patient flow. We've also seen an increase in weekend discharges as well for some of the units that are doing the regular rounding, and also length of stay, and those other things I've mentioned before.
So leading sort of right into probably patient flow there, I think there's sometimes an idea that patient flow is not my job, but certainly we think it's a safety issue. The shortest hospital stays are safer hospital stays. And we think that the navigator roles that are emerging in the system can play a real role in coordinating the inpatient care, identifying risks and acting on these, making decisions earlier in the piece, not just before discharge, but right near admission. And of course, greater use of EDD. So analysing the data that can come from patient flow portals, so EDD, waiting for what, and looking at your multiple ward move risk as well. So looking at patients that have been moved around the hospital, they're potentially at risk. And for planning purposes, using predictive tool and the dashboard from patient flow portal. There's currently a HEDI module in development, should be out by the end of the year to educate staff, and it's my understanding this is a general module that can be used by all staff. So we know the optimal time for discharge is when a patient's medically ready to go home and when their carers or themselves are confident in their ability to care at home. We see patients wait unnecessarily in hospitals, and so criteria-led discharge is one of the solutions that's been posed. We've been working with a working group around this idea. We've come up with a CLD form, a transfer of care checklist, and a draft protocol that can be used locally, a competency set and some orientation and training slides. And all of those all of those tools can be taken and used locally. I just want to talk a little bit about the huddle board or the rapid round that occurs at the patient journey board. I know this is Manly Hospital this work was presented at the Acute Care Task Force earlier in the year, and I think these meetings, in conjunction with what Wilson was describing as well, can have real benefit for planning and decision making and early risk identification, identifying patients who are eligible for criteria-led discharge, having that discussion really early on, and I think I really think there's great promise, and I know some of the teams are working on electronic versions, and I know Patient Flow Portal is also looking at an electronic version as well. So more work in this space, and I think there's lots of promise in this area. That's just a close-up version of a different type. I just wanted to go through the CLD form and the process that teams are testing at the moment. So it comes in 3 parts on a single page. The first part is where the senior medical clinician signs off the patient as eligible for criteria-led discharge or says that the patient isn't eligible. And then the second part, part B, is where the criteria are set. So it's about having a transparent discharge plan and identifying which other team members might want to feed into this process, identifying who the responsible person is, usually the nurse in charge, but that's not, sometimes they're using junior medical officers, some teams, and some teams are proposing to use allied health staff as well, depending on the structure of the team and the way that the team works. It's entirely flexible, locally driven protocol. And then part C is patients between the flags, and that a transfer of care or a discharge checklist is completed. We're not saying that the discharge checklist that we've developed has to be the one that you use. Use one that already works for your team, but if you don't have one, we're saying that, adapt ours for your use. And also having an opportunity to identify why patients aren't eligible. Did they fall off? Why did they fall off the criteria that was set, or were they not between the flags? Or trying to capture that information so that for audit purposes we can go back and see from patient safety points of view where the risks are and signed off. And then finally, I want to talk a little bit about the resource we've just released on safe clinical handover. We're now working with the CEC, who has lead on handover in the system, to put this into practice. And I'm grateful to acknowledge that the EMR team has picked up our template and have been working on mapping our suggested template with their discharge summary as well. So lots of collaborative work going on in this space. But the 5 recommendations that this report makes is number 1, front and centre, patient, their family and carers involved in the decision-making process. So important for discharge decisions. We know that those transitions of care are one of the riskiest places for patients. If you're not identifying risk here, you really are putting the patient at risk. Clear, succinct communication is essential, and we're saying electronic communications are preferred, but also you could, if a patient needs to be followed up in 48 hours, make a phone call. We kind of outlined some key places where those phone calls need to be made. Medication reconciliation at every transition of care. Greg talked about how that's a real risk. Patient or carer must leave with their discharge communications, a huge problem. We also say in that recommendation that didn't have space to put up there, but the patient shouldn't wait unnecessarily in hospital for their discharge communications. So, 2 sides of the same coin. And then a system-wide recommendation around infrastructure to enable GPs to have access to the results system at least. And certainly there is some work with the National Health Record around having hospital information sent up and then back down to the GP system that holds some promise. So just to reflect, I like to put this slide up because this gives you the contact details for the leads on those particular projects. These slides will get sent around, I'm sure. So, but in the first instance, happy to take calls and, to field information requests and things like that. But it's about, I think this project is really about how is it that we can collaborate across the system, and how is it that we can assist you to solve some of the problems you have. So.